if no other input on this first abstract, we can move on to the second. And here we're talking about a real-world impact of using luspatercept versus ESAs on healthcare resource utilization in patients who have MDS in the United States. So I can perhaps try to summarize what this abstract tried to do. So here, it basically was a retrospective cohort study that looked at patients in a healthcare database known as Symphony over some 7-year period and decided to investigate exactly how did the utilization of luspatercept change resource utilization and perhaps clinic visits or hospitalizations. So the index date, essentially what they tried to look at the data was presumably the very first time a claim by using either luspatercept or ESA was reported, and starting from May of 2020. And then they kind of monitored the outcomes afterwards. And here, what they try to show in 243 patients that they have evaluated essentially with one treatment or the other, and with a median follow-up of about 15 months for either one, demonstrating that patients who had luspatercept had a lower baseline comorbidity index, and perhaps more patients required transfusions in an 8-week period, which I think kind of is straightforward, right? Because most of those patients may have already gotten to the point where they were terribly transfusion dependent before they were treated accordingly due to the availability of luspatercept. What was interesting, though, here is that the healthcare resource utilization rate after treatment initiation was significantly lower in those who were treated with luspatercept, so lower inpatient visits, and altogether compared with ESAs. So with that, I'm just curious, what did you guys think about this abstract? What was your take on it?
Well, from my perspective, I think this is quite important. First of all, obviously, you always want to reduce utilization to the healthcare system, and I can talk about the challenges within different health systems and getting patients in for things like transfusion, and it is such a burden to the system and getting them scheduled, but also here to the patient, this really reducing that need to have to go in based on the hemoglobin, either inpatient or outpatient, to get a transfusion, and the impact that it has on the quality of life of the patient. So again, it speaks to the benefit of utilizing luspatercept and improving the quality of life of patients.
Yeah, I agree. I think a lot of times, when we do these, large clinical trials, what gets lost is sort of the patient reported outcomes and also, the actual benefit to the healthcare system. And, we know that, luspatercept, when you're, as a patient, you're thinking about, and as a provider, you're thinking about, overall healthcare costs associated with the medication, and what is really the true benefit for the patient. And if you start to have decreased outpatient utilization, inpatient hospitalization, I think you can start to see, a much larger global benefit for our patient population. So I like that this was looked into. I think, it is real world data. It's not perfect in the way that it was created and the timing, but ultimately, if there truly is a benefit in resources in patients that get on luspatercept, I think that, is very helpful and does continue to drive the case for utilization of that drug over ESAs.
Yeah, I always look at claims data very critically, just because I think it's less direct analysis. This study had almost 250 patients and about 14 or 15 months follow-up. So it was, I think, a smaller, limited study, but the correlative, makes sense that there's a reduced, healthcare sort of resource utilization, probably from transfusions and office visits. The other thing to think about is that luspatercept is a once every 3-week dosing versus oftentimes epitin alpha is weekly, so there's less utilization of the infusion center and the the staff to do the injections and this kind of thing. Maybe even some less ER visits if there is some ANC improvement. So it all makes sense. I'm just more critical of claims data. I think it's always important to actually, assay these things on the trials themselves. And if you can look at cost or when you look at transfusion need and can directly correlate that over to costs, I think that is the strongest data. But the result stands, and it does make sense from this real world data that maybe there's less utilization of resources with the luspatercept treated patients.
Yeah, and I totally agree. I think obviously this is an abstract form, and I agree with you, Chris, that we need to look at that a little more critically, because so how many people were getting EPO, for example, and going to the clinic once a week versus once every 3 weeks? And how many people would, when they require transfusion, end up going to the hospital? But be it as it may, again, it supports the fact that there is tolerability. So you started someone on a new drug, even though they were requiring more transfusions, there's tolerability, no increase in hospitalization. So you could think about it the other way around too, but nevertheless, I think we all are thinking alike on that one.